we have put a central line, and we kept all the inotropes and vasodilators ready. Because the patient was given loading dose of clopidogrel only 2 days ago, so we have gone for the GA, routine GA, midazolam, fentanyl, sleeping dose of thiopentone, ecuronium, and then extubated with neostic wind. And it was on-table extubation, and post-operative we have managed with multimodal analgesia. So on discharge, the patient was given Clexane for 3 days, later shifted to rivaroxaban and clopidogrel. The main discussion in this case would be because the ECG showed evolved MI and echo showed LV epic aneurysm. Are we justified in doing a CTCA, or we could have gone with CAG, or we could have gone with echo and ECG in hand, we can go with the surgery. So why we have opted for CTCA? Because anyway the patient is 85-year-old, and there are the chance of having a CAD is very high. So already there is evolved MI with a LV apical aneurysm. So because of there is already a non-viable myocardium. Only thing to rule out LMCA disease, we can go for CTCA. In this case we have done CTCA. What does the guidelines say? Guidelines according to 2024 ACC-HA guidelines, it states that if the patient is having acute chest pain with no history of CAD, maybe you can do CTCA. And if the patient had CTCA 2 years ago with a calcium score of 0, then if the patient is coming now, we can just go for surgery without CTCA. And emergency surgery, any emergency surgery, there is no point of going for any CT. And before taking any patient for CTCA, you just see the meds of the patient. If the meds are less than 4, and if the DASI score is less than 34, or if the functional status of the patient, if you can't assess the functional status of the patient, or there is indeterminate type of functional status, then definitely if you suspect a high risk coronary anatomy, then definitely you have to go for a CTCA. It is said that if there is SVD, the MACE cardiac events are thrice without any vessel disease, and if there is TVD, the MACE is 8 times more. What does the guidelines say about angiogram? Angiogram is strictly restricted for the highest risk patients. The routine indication for angiograms also apply in the perioperative period, like ACS or accelerated angina, despite having maximal anti-anginal therapy or any LMCA disease. And regarding troponins in the perioperative period, this is a slide showing where the troponins can be increased in the perioperative period. Preoperatively, there might be increase in troponins in the case of heart failure, cardiomyopathies, or any chronic kidney disease, or pre-existing pulmonary embolism. Intraoperative period, because of stress and massive hemorrhage, there might be increase in the troponins. And in the postoperative period, sepsis and again AKI, pulmonary embolism can increase the troponin levels in a patient. This is the chart showing the mortality rate with the troponin levels. If the troponin levels are more than 1000, the mortality rate is more than 30%. So here also the TOPT was positive, but whether it is because of pulmonary embolism or it is because of MI, it is morely clearly shows that there are ECG changes, there is LV apical aneurysm, and the RV is not dilated, the PA pressures are not increased. So we suspect that this troponin increase only is because of myocardial infarction rather than a pulmonary thromboembolism. So again comes the question whether to do cardiac intervention or to do a non-cardiac intervention first. So in this case, if you do a cardiac intervention either with a PCA or a CABG, it restricts the stoppage of dual antiplatelets. And long bone fractures, if not treated early, delays the quality of life. So non-cardiac intervention is followed by cardiac intervention. And many studies say that even if you do cardiac intervention first, the the results are not, there are no much difference in the results. And risk classification, it is widely explained in the morning. If the MERS are less than 4, there is a indicates high perioperative cardiac risk. If the EF is 35, the mortality risk increases more than thrice. Troponin trend, nowadays they say that if you measure the troponins and NT-proBNP levels preoperatively, if you add to the RCA score, RCRA score, the validation is more with adding troponin levels with it. And there are many scores considering the MI risk assessment, like TIMI score, Gray score. This is the TIMI score and this is the RCRA score. But no score will clearly tells us the exact risk of the patient going for a non-cardiac surgery. So post-operative monitoring, serial ECGs and troponins will be seen, strict heart rate and blood pressure control, optimized analgesia, and restarting aspirin and clopidogrel as soon as the surgical bleeding is controlled. And coming to pulmonary embolism with non-cardiac surgery, concerns are in any long run surgery, the DVT, the incidence of DVT is 1 to 2%, and the pulmonary embolism will be like range from 2 to 22%. So here we would maintain normovolemia, we would avoid the overdose of drugs during induction because there is slow circulation time, avoid increase in ventricular afterload, avoid sudden hypotension in regional anesthesia, and avoid increase in PVR with avoiding hypoxia, hypercarbia, hypothermia, acidosis, and using nitrous oxide in the intraoperative period. This is the pulmonary embolism which can happen in the perioperative period. The first one shows the risk assessment of the patients going for surgery. This is a Caprini risk assessment score. There are other scores like PODA score, which tells whether the patient is patient is will be getting any pulmonary thromboembolism or not. Once risk is seen, then we will see whether the patient is hemodynamically stable or not. If the patient is not hemodynamically stable, then definitely you have to go for pulmonary thromboembolism treatment as such. So post-op management, always anticoagulant started as soon as bleeding risk is minimized. Start low molecular weight heparin and start DOACs 24 hours after surgery. Always there are new AS ASRA guidelines 2025. It can be easily seen. We just want to see whether when to stop the anticoagulation and when to start. They are clearly given in the guidelines. And post-operative period, this patient had hemoglobin of 6.8. So there are guidelines. There are two strategies: the restrictive strategy and the liberal strategy. But in the MINT study, it was clearly shown that there is no big difference in the restrictive or liberal strategy. But since the number of complication rates are little lesser in liberal strategy, we usually go for a liberal transfer strategy. And here the trichomesis risk stratification is very important and multidisciplinary approach. And you should individualize the management according to the patient. And as already said, means myocardial infarction after non-cardiac surgery, knowledge about perioperative troponins is very important. Thank you.